I think as paramedics, we can really address some of the health inequity problems that so many of our patients have, just not being able to make it to that specialist clinic, right? We have the rural section as well of the county that an hour drive to get down there, KGH. And if you have, CHF on the precipice of decompensation, you probably don't want to take an hour taxi or drive down the KGH.
Yes.
But if a CP can come and maintain your medications, make sure that you're catching exacerbations really early, that can have such a huge impact to those patients.
Yes.
Then we do that across multiple comorbidities like that, we can get a huge difference. Do you think that would, I guess it could go both ways in terms of every paramedic becomes this generalist where, yes, there's a resuscitation aspect to it, and then there's treat and discharge, treat and refer pathways? Or do you think it kind of would lead the way for more specialization, where you have some paramedics that are very good at resuscitation and like advanced resuscitation, but then you have also paramedics that go to those lower acuity calls that are excellent at more in-depth, primary care type exams and treat and refer pathways? I guess kind of at a crossroads in that sense.
I think that really depends on the system in which you work, right? Like in a larger urban center, I see that, those specialist paramedics that can make it to the calls relatively quickly for a resuscitation. Because if you're not making it to the resuscitation in really a relatively short period of time, your return is quickly diminishing, right?
Yes.
So in a rural setting, I don't see that being as effective if your resuscitation specialist is coming from 30 minutes away.
Yeah.
It might work a little bit better in a larger urban center. But I do see paramedics probably mostly seen as generals, because we do need to do that work in the resuscitation, the shortness of breath, EMIs, like that's our bread and butter. But I do see the profession evolving to develop some of these specialties, right? So CP being one, maybe tactical or other specialty teams, education, things like that. And the career framework for paramedics that the PCC put out, it was just last year, right? I think that does a good job of describing the future state of education and the profession on how it'll develop, with that foundation of education.
And that brings up Dr. Alan Batts and Dr. Walter Tavera's research, how that's kind of the framework where we're going to go down. And it's so cool that we're thinking from a systems lens, but we've all heard this. It's like, so much has changed. I have so much cognitive overload, and it's hard to see the bigger picture when you're just like, I'm just tired. And I don't feel like I know this material. I don't know palliative care. Let's say, we hear that all the time. Or the classic, it's like, I want more money if I'm getting more things. So it's a complicated problem when you're trying to improve the system as a whole.
It sure is. And I certainly believe that our change has outpaced our education, whether it's the foundational education or our continuing education.
Sure.
I think we do need more time invested in ongoing education. And you look at other professions, let's use police and fire. The amount of training that they have for ongoing education outstrips ours quite easily. When paramedics first got symptom relief many years ago, they had 8 hours of training. 6-ish medications. We still have 8 hours of training for PCPs. And how many medications and protocols do they have now? In the span of 20 years, we've gone from 6 to 40 medication, and we've gone from 8 hours to 8 hours. Like same. Like that's a problem. And no wonder people, especially through COVID, when we've seen this rapid change, so they would have been with, the constant changing COVID protocols that sometimes changed multiple times a day, at least weekly for quite some time.
Mm-hmm.
And then we're adding one thing after another, but not providing that time to get comfortable with it or enough training, maybe initial training, but certainly not that training to reinforce it over and over and over again to get really good. And I do see that as a problem we need to solve.
I think it's such an excellent point. And like you said, the gap in education is just so significant, because you're taught, at least initially, and for I think a lot of years, was, defaults to just take innovation to the hospital because that's what's best. Like, unless they truly refuse to go. But now things are really changing to that, with palliative care. That's the last thing we're going to do with the patients. It's a complete 180. Like, we're going to stay on scene for 2 hours. We're going to make them comfortable. We're going to have a great conversation with their family, do some coaching, education, all that stuff. And then we're going to leave. Like, that is such a dichotomy from the rest of our job, right?
Yes.
And I think, the primary education needs to definitely catch up to allow for that flexibility in practice.
Yes.
Sometimes you're going to go in and run a cardiac arrest, get a ROSC, and go to the hospital. And sometimes you're going to stay on scene for 2 hours and make a patient comfortable and have that like shared care model with their physician, like doing those updates and things like that. The palliative care team is just so diverse now.
Yes. Yeah. And we need training to do that and get good at it as well. And I think systems, education systems and professional systems are already in place that we don't have to reinvent the wheel. Like, this is not something that's new to paramedicine, right? You look at, nursing as a good example, or education, teachers in particular, right? They finish their entry to practice education, and they still have more things to do after that, right? As a teacher or a nurse, they don't do extra, whether it's 2 or 3 courses, they get another certificate that, gives them English as a second language certification, or math specialty, or a nurse, right? They might specialize in emergency or cardiac or any number of things after a series of courses, and very much see paramedic education following and doing the same thing.
If we could wave a magic wand, I've always thought this. Imagine we could spend 40% of our time training and the rest of it was clinical. How many people would we improve the quality of life, improve their careers? Because the common thing we all hear is that I didn't sign up to do palliative care. If I started 20 years ago, I signed up to be a resuscitator, and now you're pushing me down a realm I didn't necessarily choose. And I can respect their preference, but I can also respect the needs of the healthcare system.
Mm-hmm.
And we overcome that, the patient's need in the moment too, right? We all take these people to the hospital, and our job is to provide the right care at the right place and the right time, no matter where you are. So,
because I think if you look at any profession, you might see aspects in that, right? Like a police officer signed up, 20 years ago or 30 years ago, maybe, they didn't want to be doing mental health calls all the time and doing a lot of social work, right? Wanted to fight crime and catch bad guys. But that's the way the profession evolves, right? Maybe firefighters only signed up to do fire suppression. Now they're doing a lot of medical calls, but that's, it's the way the profession changes them. Mm-hmm. We have to keep up. And, I completely get where those folks are at, but, and maybe they're uncomfortable with it because they don't have that education. And it is scary learning these huge new things from, okay, this is the way I've done it for 30 years. And now you want me to change, right? We didn't put everybody on a backboard anymore when that changed in the BLS. Folks that have been in paramedicine for 20 years, like, we've always put people on a backboard, and, they would be asked why they didn't in a lot of situations. And now you're telling me not to put them on a backboard? Like, we're going to kill people was the thought process there. But it's just a matter of educating, following, and, you got to change with the system, right? A lot of professions are not what they used to be 20 years ago. Nursing's not, police aren't, teachers aren't.
You always go back to line, both things can be true. You can be uncomfortable with this and it's a change in your identity, but it can also be true. We need to adapt and change for the best of the patient and the healthcare system. And just anecdotally, I'm sure we all experience it. As soon as you give them enough education, like palliative, why are we doing palliative? It's like, well, the vast majority of Canadians don't receive palliative care in the community, and they end up in the hospital, which is where they don't want to. And we can provide that. And they're like, oh, really? And it's like, yeah, because that's the point of us. We're able to go in the community and give these meds because we're that good.
Yes.
But we need good training to do it, to support you. What do you think are the biggest challenges in the system right now to provide that education to the paramedics? We only have 8 hours for PCPs. That's pretty obvious that needs to change. Like, what do you think are the biggest barriers currently?
I honestly think it's probably a lot to do with funding, right? So the Ministry of Health funds so much training for paramedics, and that needs to change. But even as municipalities run paramedic services, we also need to recognize that we do need to provide more training than we currently do. I think the demands of the profession currently limit that too. You look at our staffing resources, especially since COVID. It'd be great to provide paramedics more training, but we also have to have more paramedics to backfill those folks, which has been a struggle, across the province, probably the country and internationally. So that's one of the struggles. So funding and resources are the two big ones. Time also fits in there as well. Like, when are you doing this? How do you do it? Are you taking people off the road for a full day? Are we giving them time off to do online training or some kind of combination thereof?
Just seeing with the new people coming in, I always tell them, and say, you come in probably the best time in the Ontario paramedic profession because we're just exploding. Where do you see it all going in 10, 20 years?
10, 20 years? I think there's probably, we're on the precipice of really big changes in our field. And I think once it starts, it's going to rapidly change. Like, once you push that snowball down the hill, it's just going to get going faster and faster, bigger and bigger, and just envelop everything. But, the education system's on the precipice of changing from a 2-year diploma to a 3-year degree at the college level, and will probably continue to evolve to a 4-year undergraduate degree at universities for entry to practice. So I think that opens up a huge area for paramedics as well, right? As you get that more education and build that system of, okay, so now we're done our undergraduate degree. What do we see after that? Like we were talking about earlier with those, micro credentials afterwards, and then master's level training, PhD level training. So all that'll quickly develop once it starts going. I also see work being done to get a paramedic regulatory college as being that almost adjacent thing to the education system as you're developing this and have different entry to practice, building that, paramedic college would be essential for the profession to grow and develop. And that self-regulation, I think, opens up a whole other world of what paramedics will be able to do, where they're able to practice. I have heard from time to time, sometimes people think they're stuck in paramedicine because there's not other avenues to go, which I would contend that's not entirely the case. But if you look at police, right, you could go to investigations or, it could be a dive team or like any other kind of specialty teams, right? In paramedicine, if we have more education, a regulatory college might be able to go work in a primary care facility, working in the ER, or, maybe some kind of community paramedicine that looks like a physician's assistant, right? Yeah. Jacob's on a call and it's just Nana who slipped and fell, has a simple laceration, needs some stitches. Well, he bandages her up, leaves her at home, calls you up, and you answer the phone, he gives a report, and you're like, yeah, I'll come see Nana and stitch her up. Perfect.
Like, cool.
All of this, like, these are all huge possibilities for us.
And these are models that exist in other places. So like you said, we don't have to reinvent the wheel. We can learn from them.
We're almost just catching up to other places that are ahead of us.
Yep. That's good. What special projects are you doing in Frontenac?
Right now we have an education team, which I think is still in development and can still has really good growth potential, and I think can support some of those things that we were talking about, right? Revisiting things, helping train their colleagues, really mentoring new folks. So that's something that I think is it's near and dear to my heart. We also have a bike team in development, which will give a little bit of change to paramedics and get them doing something else. We have lots of other initiatives like updating our PTSD plan, trying to get more mental health supports for paramedics. And feel like we're on a little bit more of a loss.
Mm-hmm. Well, I think Frontec's been really good at leading the way for community paramedicine as well, and that's been a really good, like you said, Some paramedics feel like they might be stuck because they don't want to just continue climbing the chain, like words like suit DC and things like that.
Yes.
They want to make a lateral move to something else. And I think community paramedicine allows for a great opportunity for that.
Yeah, great point. And our CP program, our CPs are getting training with Dr. Mufla for, treating CHF patients outside of the hospital and keeping them well at home. And we were talking about that a little bit before we started. And I think you guys have already spoke to Dr. Mufla on another podcast. So, great guy, incredible physician, and I'm thrilled that we're involved in that and to be able to really bring that care to the community and patients to help them stay at home, because I'm sure they don't want to come to a hospital.
No, that's exactly what we were talking about with him. So that's a great point. I think that kind of is a good example of an area of opportunity for more collaboration between like these paramedic services and hospitals and educational institutions, like with us and Queens and KGH. We can all really work together and bring healthcare to the patients where they need it.
Yes.
And that's a really good case study of what could be replicated for other complex diseases.
Yeah.
Right?
Yeah. When we look at this area, right, like big things are CHF, COPD, diabetes, all things that paramedics are at least have a really strong foundation in, and it's just maybe upgrading their training a little to not immediately dealing with the emergency part of that, but what is the longer term treatment and stabilization and prevention parts of managing those disease process.
I think as paramedics, we can really address some of the health inequity problems that so many of our patients have, just not being able to make it to that specialist clinic, right? We have a rural section as well of the county that an hour drive to get down there, KGH. And if you have, CHF on the precipice of decompensation, you probably don't want to take an hour taxi or drive down the KGH. Yeah. But if a CP can come and maintain, your medications, make sure that you're catching exacerbations really early, that can have such a huge impact to those patients.
Yes.
Then we do that across multiple comorbidities like that, we can get a huge difference.
Yes, for sure. And even, taking that one step further, if they are on that precipice, right, it might be quite appropriate to access through the 911 system, but then again, not being transported, but being treated and referred. And then that CP comes out.
Exactly. And then you have, with those CPs, you have a direct line to one of the world leading cardiologists in CHF that can help you guide that treatment. Yeah. So I think that's just an amazing system and a good case study for what the future could look like. Yeah, for sure. Can you even imagine saying that 10 years ago in this career? Yeah. Because 10 years ago, you'd be like, let's go to the hospital. But now it's like, we can get a CP to follow up. We can consult the cardiologist and everything. You're going to have a full spectrum of comprehensive care, prevention, treatment, and prophylactically preventing the next episode. That's really cool. And I'm not just saying this, but I've heard Frontenac has one of the best CP programs in the province. So kudos to all the your employees and everything.
Thank you. Yeah, our CPs are amazing. They do a lot of good work and very powerful work.
Can you give an example of one of the most moments you're proud of, like one of the stories that they've shared and treated for a patient?
So there's a couple that come to mind, and this is an example I regularly give. So one of the things the CPs can do is give fosfomycin for UTIs. So if you catch a UTI early and give that one dose of that antibiotic, $30, around $30, you could have really saved that patient a lot of time in the hospital and really prevented the whole system from dealing with potentially like a uroseptic patient that can, we know in the elderly patients, it can progress quite rapidly. So you're saving thousands, tens of thousands of dollars in the long run, but it's also really patient-centered. Got that one antibiotic, you took it at home, very early stages. So, that's an incredible thing. It blows my mind that we don't regularly do this. But as well, another story that comes to mind is even CPs helping with, not, completely mental stuff. And so there was a patient who was struggling after having taken out a loan from one of those quick day loan places. And one of our CPs got that sorted out for her. So how much stress did that alleviate from the patient and the financial burden? And, when you think of those social determinants of how you're struggling to manage that, and that's putting a huge amount of stress on you and probably affecting other aspects of your health, like that, isn't necessarily a medical intervention, but certainly had huge impacts for that patient and their stress levels. So that's another great example. And that's where I think CPs really succeed, right? They know how to find our ways to help the patient.
Yeah, I think they do such an amazing job as like care navigators, right? You have this patient that might have a degree of like dementia or just these systems are so complicated to manage on their own. And you have a CP there that can respond to rapid deterioration if it does occur, but also just help navigate, like, here's your cardiologist, here's your endocrinologist, here's all these complex medications or treatment plans. And that just makes such a huge difference, because we were talking about this with Dr. Oz yesterday, but you can prescribe all these medications to these patients and give them like a gold standard bundle of care. But if they don't take the medications because they're not sure why, they don't like the side effects, it's just not going to have an impact on their health. But the CP going there and be able to spend an hour and say, that's what this pill does, that's why it matters to you. That's what this pill does, that's why it matters to you. And like that motivational interviewing kind of practice, I think it makes such a massive difference in their lives. And that's what I see in my short practice as a CP, and it was really beneficial.
Yeah, and we've heard stories of CPs going in, doing those medication checks, and there's months, years worth of medications, like they're bringing a garbage bag worth of old medication, without exaggerating, right? They're taking them to the pharmacy that we have connections with to dispose of them properly. You think of how much money of medication is just essentially being thrown out, but also looking at the patient, like how much benefit wasn't received from taking those medications, and how that maybe contributed to their progression illness. Right? It's a huge loss for the healthcare system.
I think just changing the perspective to the paramedic too, because if you get called to somebody 911, my money is insecure, I took out a loan, it's not working well, you'd be like, code 71, I'm gone.
Yeah.
But having that extra knowledge, and this is that whole holistic perspective of the social determinants of health, it's like, it's not medical, but it will impact your morbidity. If you're so stressed out about this, let's figure it out and sit down and have a conversation.
Sure. I think those conversations about, social prescribing and system navigations, those have huge impacts on patients as well. Like beyond the actual, medication taken, like, or procedures wise, right? Connecting folks with other resources through the community. Like you had said, like we have a complicated system, and it's not just the healthcare system, right? Like there's lots of services out there for people if you know where to get them, or how to find them, or how to get registered for them, which could also have huge impacts to patients and their illness trajectory.
And that goes back to the point that obviously there is a small amount of abuse of the system, but that small amount, most people is like, I need help. I have no idea how to navigate the system. And paramedics are extremely good at helping navigate when they have the training and the resources to say, hey, you need this. You need diabetes management. Let me help you and everything. So I think that's where we are coming in to help expand people's health. Yeah, I think when you brought in the perspective for community medics, and everything that prevents disease progression and makes your patient's life better is your responsibility. It's not just like making sure they get their meds or managing the diabetes, and literally everything for that person to stay happy and healthy at home, right? And it's just such a beautiful paradigm shift for our profession. Why would you not want to stay at home? People generally don't want to go to the hospital. As much as surprised, they don't want to go. It's like, let's treat you at here. It's patient-centered. It's equitable. Let's do what we can. I think it goes back to your phosphomimetic example, because you imagine like 10 years ago, you have like old lady osteoporosis and pain like in her knees and stuff like that. The journey for her would be, okay, we're going to take you outside of your house. We're going to put you in a stretcher. We're going to bring you to the ER. The ER is full. We're going to put you in the waiting room for 8 hours. You're going to see a doctor after 10 hours. They're going to do your urine. Maybe 2 hours later, you're going to leave with macrobit.
Yes.
Okay, that's been your journey. Then you're going to take a taxi to get back home. Okay, cool. That's a whole day of your life that's been spent in an incredibly loud, uncomfortable environment. No. You see your CP, they do a UTI history, they do point of care, UTI test type, they give you this dilutable antibiotic that tastes like grapes, and that's incredible. Like that's such a big difference for them.
Yeah.
And it's funny, we forget, like when we drop them off in the waiting room, that's the end of our interaction with them. But when you see them later on, they stare at you and they're still in the waiting room, really. Like that's terrible, right? It is. We've all been there person, like, I don't want to do that. And you're telling me you can treat me at home and prevent all that? Please do. Then you talk about the return of investment. Thousands of dollars could be saved if we treat that. It could be reinvested into the system to help further people.
And I think it's a cycle that is only going to improve upon itself. Right? The better we get at getting people the right care at the right time at the right place, frees up the ER to do what they do best, and get people through that system quicker and not dilute it. So our paramedics can get there with patients who truly need to be at the ER. They weren't I can't really look for that treat, refer, release, or discharge, right? Yeah, maybe it's broken bone. Still a relatively straightforward thing, but has to be managed in the ER. But maybe that's just my limited thinking. It will eventually be cast to people at home. But until then, I think it's quite reasonable if you have a broken femur, you end up at the ER. That's an emergency, right? So that person's getting seen faster. Our paramedics are getting out of there. It's good for the whole system to make these investments or changes sometimes, right? These little changes can have really huge effects.
Do you know the number of hospital or 911 calls that your CPs do? Like, how much do they prevent of actual 911 calls?
That's a really hard metric to come in with. And we've had, various people try and come to figure that out. And I don't think we have really good metrics on that, unfortunately. And I was remarking to Jacob earlier, it's that prevention piece that is really hard to hit a budget line, right? So, and that's kind of where the system falls down, right? Like we look at things with evidence, and when you're looking from a budgetary perspective, right? What is the evidence? It's the budget line, right? I don't have a budget line for what did we prevent and how do we measure that, right? Preventing a UTI, maybe that prevents one visit to the ER, maybe it prevents, 2 weeks in the ICU, right? So there's a pretty big, range of how much we could have prevented there. I don't think we have got to the point of getting a really good measure on that.
It is hard. The way that we evaluate systems is very much first order effects. And all of these like CP related improvements in the system are often second and third order effects. They're massive, but very difficult to measure.
And it doesn't help that we have disconnected systems too, how we pull data. And, I can't go check when Mrs. Smith entered the hospital and why, and was that something our CPs could prevent or have access to that information? Right. So it's, when we have segmented systems and we're trying to figure out what 911 calls we prevented or could have prevented, right? We need, a couple more layers of information. So I think we're starting to break down some of those barriers, but there's still ways to.
It's a good research study. I think you should look into that. That list is getting long.
Right?
Because you hear, like, they say it because usually, like, a community paramedic calls 911 because the patient needs to go to the hospital. It's like, I've done what I can. I've exhausted my options. They need to go. And they'll be like, oh, you didn't do your job, right? It's like, but you'll never know the calls that didn't happen because they kept them at home. And that goes back. There's a gap. How do we calculate and track it? Big data and trends is going to be the solution to that, I think. But like you said, the siloing does present barriers. We've got some work to do. Yes, it's doable. Last couple of questions. Did you always want to be chief? Was that your dream?
Yes.
Awesome.
I kind of very early when I saw two paths, there was to be a chief or to be an educator. And, I'd started down both paths, and just the way the college system was when I was, spending a good chunk of my time there, that path didn't continue. And so I knew from very, very early that I wanted to be a chief. I remember probably one of my first performance appraisals. What are your goals? And I was young and probably too arrogant, but I just wrote on there ACP, comma, chief. That was all that I wrote on it. And I look back at that and I am embarrassed that is what ended up on there. But I was young and arrogant and a little stupid. And but I mean, so I knew that from a early on in my career. I think that made decisions throughout my career a little bit easier, like knowing that end goals.
Mm. So let's say, we always ask this, you come to the end of your career, what's the benchmark to say this career was a success when I was a chief? Like, what would you have to meet for all to be satisfied with that?
Wow.
It's a deep question.
I don't know if I would ever be completely satisfied.
Yeah.
So I remember a question from my wife when I did get this chief position. She's like, okay, so like we can slow things down, right? Like you're not constantly striving for that's that, right? Like we can have a breather here for a bit. I don't know why, because like everything, since we've known each other, right? Like it's always, chasing that next thing. But I think if I could look back, it would be, leaving this workplace in particular, but maybe the profession as a whole better than what I found it, right? And even if those are small contributions, right? Because we're trying to make huge system changes. So nobody's going to do that on their own. Was I able to contribute things that made positive impacts, right? And I think first and foremost, for the people in Frontenac, that's who I'm ultimately responsible for and feel the most connection to, because there are folks. But then to a broader perspective, the system and the healthcare systems and to the patients, right? What I contribute in my role, did it make patient care better? Did it make paramedics better? Did it provide them more satisfaction and enjoying in their roles? Things like that.
That's a good answer. And we spoke about this yesterday when you asked the brilliant question of, there's certain people that are so type A, they're always chasing. And you obviously had those goals and you've strived and met your goals, but you want more. Is there a strategy you have that finds satisfaction when you have, but still striving for more?
Yes. Yeah. I am very satisfied with where I am, and I feel privileged and honored to be here. But like I said, like to be a leader, you need to be a lifelong learner too. So there's still things that I have been seeking about and want to achieve, whether it's, professionally, personally, or academically. So there's still things that I'm looking at doing and moving those forward, because I have a hard time staying still. Not satisfied just to arrive somewhere and be satisfied with it. That's just not. That's not me.
That's okay.
That's okay. Yeah. And like I did try and take a moment when I first got the job. I'm like, okay, like just take a moment and recognize where I've got to and just enjoy it for a minute. And I think I did enjoy it for a minute. And then I'm like, okay, now what are the next steps? How are we building this plan? How are we moving forward?
You find that fun and satisfying to be busy and contributing?
Yes. I sometimes find it odd when I'm not busy. Yeah. So I think back now, it was a long time ago and I wasn't in the role I am, but when I went on vacation down south with my wife, right? She's the type of person who could sit on a beach and just lay there all day. I was done the 2 books that I brought in the first 2 days and bored out of my screw that. It's really hard to go from 120% most of the time to she's like 5%, right? I was a hard tried that.
Oh, it's hilarious that I can so empathize with that. Just sitting on the beach and being like, there is no peace in idleness. I don't know what to do with this.
Like the days I enjoyed most were when we, took an excursion, went out and saw things and did things. Like I really like that. It's hard to idle.
I think it's amazing when someone's like personality and intrinsic drives just match with their career and their career progression. So it's pretty obvious that that's what's happening here. We said yesterday, the discipline doesn't come from doing the work. The discipline comes from not doing the work. Sitting on the beach, reading a newspaper and be like, this is awful, can be the hardest thing you do. Yeah.
Yeah. And I mean, there's, I'm thankful. So there's new presidents in the office working, and he regularly checks in and is like, you're off to one, right? Like, I don't want to be seeing emails.
That's so nice.
And I mean, I appreciate that. And he's looking out for my well-being because he knows, like, you got to take a break sometimes. And I try and do that. It is hard sometimes. Other times it's easier, but
that exemplifies your relationship with the union. And they're like, you need to take a break, because other people are like, I'm still going to pound you with emails and you're all break. So that just shows how good of a job you're doing in Frontenac. Thanks so much for your time and for joining us today. It's a really amazing conversation.
Well, thank you both. It was fun. Thank you.